Welcome to Dr. CM Edcast, your go-to resource for medical learning. Through discussions, case studies, tutorials, and debates, we help you learn, grow, serve.
So how exactly does a simple pill calm a storm in the brain? How can a drug quiet an overactive mind and help someone fall asleep? Well, it's not magic. It's all about precise neurochemistry. And today, we're going to break down the exact mechanisms behind the drugs that quiet the central nervous system. This brings us to the world of anxiolytic and sedative hypnotic pharmacology. These are the specific drug classes designed to tackle anxiety and insomnia by essentially turning up the volume on the brain's own calming signals. Okay, here's our game plan. We're going to start with the absolute core mechanism, the GABA-A receptor. Then we'll compare the old-school barbiturates with the much more common benzodiazepines. After taking a closer look at benzos, we'll check out some newer drugs, and then we'll wrap it all up with some high-yield clinical guidelines that you'll definitely need for your practice and your exams. Pretty much everything we're going to talk about today comes back to one central player, the GABA-A receptor. You can think of it as the master switch for putting the brakes on the central nervous system. If you understand how this works, you've mastered this entire class of drugs. It's that important. So the star of the show here is GABA, which stands for gamma-aminobutyric acid. It's the brain's main off switch, the primary inhibitory neurotransmitter. It's like the brake pedal for your neurons. When GABA is released, it quiets things down, which leads to feeling less anxious, muscle relaxation, and sedation. Now here's a crucial point. The drugs we're discussing aren't GABA themselves. They don't push the brake pedal. Instead, they're what we call positive allosteric modulators. They basically make the brain's own foot push that brake pedal way more effectively.
Now, if you could zoom in on the GABA-A receptor, you'd see it's not just one simple piece, it's a whole complex. GABA itself latches onto what are called the alpha and beta subunits. When it does that, it opens up a channel right in the middle, letting chloride ions rush into the neuron. And for our purposes, here's the key part. There's another totally separate spot on the gamma subunit where benzodiazepines bind. Okay, this slide right here, this is probably the single most important mechanistic difference you need to burn into your memory. Both drug classes help GABA out, but they do it in different ways. Benzodiazepines make the channel open more frequently, but they still need GABA to be there to work. Barbiturates, on the other hand, hold the channel open for a longer duration. And here's the dangerous part. At high doses, barbiturates can force the channel open all by themselves, even without any GABA. This is exactly why they're so risky. They can cause profound, unstoppable CNS depression, whereas benzos have a built-in ceiling to their effect. And that key difference in their mechanism of action perfectly sets the stage for the story of barbiturate versus benzodiazepines. You see this all the time in pharmacology. An older, clunkier drug class gets replaced by a safer, more refined successor. This table really spells out why we moved away from barbiturates. Look at that safety margin. It's narrow. That means the line between a therapeutic dose and a fatal dose is incredibly thin. There's no antidote for an overdose, they're highly addictive, and this last one is a big deal for exams. They're potent inducers of liver enzymes. That means they mess with the metabolism of tons of other drugs, making them a nightmare for drug-drug interactions. On every single one of these points, benzodiazepines are just flat out better and safer. All right, so let's zoom in on the modern prototype class, the benzodiazepines. For clinical practice, and especially for your board exams, when you see a question about benzos, they're often testing principles that are best represented by the prototype drug, diazepam. If you understand diazepam, you really understand the whole class.
Now, not all benzos are created equal. The main way we classify them is by how long they stick around in the body, their duration of action. This is all about their pharmacokinetics. So the long-acting ones, like diazepam, get broken down into other active compounds, which extends their effect. This makes them great for things that need sustained treatment, like generalized anxiety or alcohol withdrawal. On the flip side, you've got short-acting agents like triazolam. They get metabolized and cleared out fast, which makes them perfect for insomnia, because you don't want the patient to have that next-day hangover effect.
These 5 core actions are all direct results of boosting GABA's inhibitory effect all across the central nervous system. You get the anti-anxiety effect from its action on the limbic system, sedation and sleep from the reticular activating system. They stop seizures by calming down overexcited neurons, and they relax muscles by acting on pathways in the spinal cord. It's this widespread action that makes them so incredibly versatile.
The side effects are pretty much a logical extension of what the drug is supposed to do. The most common ones are just too much CNS depression, drowsiness, and ataxia, which is just a fancy word for impaired coordination. Anterograde amnesia, where you can't form new memories, is also a classic effect. Of course, the risk of physical and psychological dependence is a huge clinical problem. And the one drug interaction you absolutely cannot forget is with other CNS depressants, especially alcohol. When you mix the two, the effect isn't just added together, it's multiplied. That synergistic depression of the breathing centers can easily be fatal. So what happens if you suspect an overdose? Well, lucky for us, we have an antidote, flumazenil. It works by basically kicking the benzodiazepine off its binding site on the GABA-A receptor. But here's the catch, and it's a big one. Flumazenil has a very short duration of action. So if you just reversed an overdose from a long-acting benzo like diazepam, you're going to have to give more flumazenil, or the patient will just slip right back into sedation as it wears off.
Okay, so we've covered the classics, but pharmacology, of course, is always moving forward. Let's take a look at two newer drugs that give us more targeted ways to treat insomnia and anxiety, moving beyond that classic benzodiazepine profile.
So here we have two completely different strategies for getting more specific. On one hand, you've got zolpidem. It's not technically a benzodiazepine, but it acts selectively on one specific part of the GABA-A receptor, the alpha-1 subunit. This subunit is mostly involved in sedation, so you get the hypnotic effect without as much of the muscle relaxation or anti-anxiety stuff. Then, on the other hand, you have buspirone, which just throws the whole GABA playbook out the window. It works on the serotonin system as a 5-HT1A agonist. This gives you anxiety relief without any of the sedation, amnesia, or dependence that comes with the GABA drugs.
Buspirone's profile is really appealing for someone with chronic anxiety. You get anxiety relief without making them sleepy, messing with their coordination, or interacting with alcohol. And most importantly, there's no risk of abuse. But there's a huge clinical trade-off. It has a delayed onset of action. We're talking 1 to 2 weeks before it really starts working. That makes it totally useless for an acute anxiety situation or a panic attack.
All right, we've gone through a ton of pharmacology. Let's pull it all together now into some practical advice. This is how you actually apply this knowledge in the clinic and what you absolutely need to have locked down for your exams. Here are the key principles for safe and effective therapy. First, you must always taper the dose gradually when stopping to avoid a nasty withdrawal syndrome. Second, you've got to match the drug's properties to the patient's problem. Short-acting drugs for sleep, long-acting drugs for ongoing anxiety. Third, be extra careful with special populations. You'll need to lower the dose in the elderly and in patients with liver problems to prevent the drug from building up to toxic levels. And remember, the goal is always to use these for the shortest time possible, ideally alongside psychotherapy.
And this all leads us to a really central question in modern psychopharmacology. We know these drugs carry a clear risk of dependence. And we have newer, non-GABA agents like SSRIs and buspirone for chronic anxiety. So, what is the role of the benzodiazepine today? There's no question they are incredibly powerful for acute situations. We're talking panic attacks, seizures, anesthesia. But for long-term management, their exact place in therapy is something that's still being debated and reevaluated by clinicians all the time.